Good morning, everyone. I'm Robin Shapiro. I'm the board chair of Health Advocate X, and you're finding yourself at another Community Conversations. Today is July 10th, 2023. I'd like to start off by reading a safe space statement and establish this meeting as a safe space. So that means that every voice will be heard and respected. And we understand that we enter this space with different lived experiences. So we recognize that there's the potential for unintentional harm. And as an organization, we are committed to healing should harm occur. And I'd also like to offer a land acknowledgement. Today I am in Seattle, Washington, which is part of this unceded land of the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people. I'd like to acknowledge the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people and community and pay my respects to their past, present, and future elders. So today we are going to be talking about diagnostic advocacy. We have special guest Dolka, who is the founder and chief care officer at GreyZone Health, which we've known and loved EO for a very long time. So it's great to have her here on our community conversation. But before that, we have the very esteemed Dr. Dale Reisner, who is the former medical director of patient quality and safety at Swedish Health Services. And she's going to be talking about some public health information. So we're switching to broader topics on public health. And today she's actually going to be talking a little bit about ticks and Lyme disease before we get into diagnostic advocacy. Thank you and welcome, Dale.
Yeah, so you guys are going to think like, what has become of this lady's brain? She's talking about the nasty little ticks. I think that we are so lucky to have EO here today to talk about diagnostic challenges and sort of how to approach those, both as an individual and as an advocate. And one of the things in the public health arena, for sure, is diseases that are spread across the country. So tick-borne illnesses are, and there are many of them for those of us that live in the Pacific Northwest that we've been feeling pretty comfortable about because they don't tend to hang out in our cooler, wetter clime. But as the climate warms up across the world, and certainly across our area, we're seeing more. Certainly people travel all over the country, so that's another way to bring them around. And the information that I'm presenting today is pulled primarily from the American Public Health Association as well as the CDC. And the CDC does track this, and the American Public Health Association has policies related to recommendations for government focus on some of these tick-borne illnesses. I'm not going to talk about mosquito-borne illnesses today, but there's plenty of those to be concerned about as well. Many of those are easier to diagnose and a little bit better understood. So with that, I'm going to talk a little bit about why this is so pertinent for today's key discussion. The problem with tick-borne illnesses, and there are many of them, is that they're complex, and that presence of ticks for those that are out in the wilderness or working in even, those OSHA's involved in this because those who work clearing roadsides and things like that may be exposed, is that people will get, that are in those areas will get a tick and pull it out or get it out and think, okay, fine, the thing is off of me. And there is a bunch of information about how you remove the tick. We can talk about that if you have questions at the end, as well as how long the tick is in place and whether you even notice it. and the longer it's there, the more likely you can have a disease come from it. And not everybody's going to get a disease from a tick bite for sure. So nobody really knows what the transmission rate is because so many people sort of normalize ticks. But fever and chills, every tick-borne disease can cause a fever. Aches and pains. So, right, I'm getting into more and more common things that we have, and rashes. So they don't all have rashes, but the ones who do have rashes actually have fairly distinct rashes. So if you identify that you've had a tick bite and go to someone who's aware of this, they may be able to help figure out what to test for. The geographic region where you're bitten is important because of the spread and where ticks are hanging out in particular. I wanted to mention, though, that there are 3 that really are spread across the entire country. All of these are more concentrated in either the Northeast, primarily in the Northeast, actually, or in the central, southern, eastern part of the country. However, as I said, some of them are spreading. So, for instance, Lyme disease is now everywhere, still heavily focused in the upper part of the Northeast. And the Great Lakes states. The Rocky Mountain spotted fever is also across the entire country, spread by a very aggressive little tick that will actually detects body heat and runs after you. Crazy.
Isn't that amazing?
It sounds like science fiction, right? Tularemia, which is an old tick-borne illness, has been around forever, is actually very light in its concentration of causing illness, but it's across the entire country as well. And ehrlichiosis is another one that is more spread, again, not so much in the Pacific Northwest, but spreading into the sort of southern Texas area as well. There's a couple other ones that are really more concentrated, again, in the upper part of the country. And with the symptoms, I thought to emphasize that early detection, there's obviously prevention. You're going to always hear that first, right? If you're going places, doing things for prevention, I'll sort of summarize those when I'm done talking. But the other I thought I should highlight is Lyme disease, since it is really the most prevalent across the country. So if it's not diagnosed early and treated properly, it can cause serious health effects, particularly long-term. And I think some of this discussion feeds into difficult to diagnose illnesses. And when people get brushed off because the constellation of complaints doesn't make sense. So about 90% of the tick-borne illness that results in frequent medical visits and so on is caused by Lyme disease, and by Lyme disease that wasn't identified early and treated early.
So wait a minute. So wait, go back to that statistic. 90%
of tick-borne illnesses across the US by Lyme disease. Okay.
So, and I think it's important to note, because I have a personal experience with a very good friend who's a young person who was bit long before she had any symptoms. And so it took a lot of unwinding to understand what exactly it was she had. So I think that that's relevant also for the audience to understand.
For sure. Yeah. And there's even recommendation that if you do get a tick bite and you remove the tick to actually hang on to it, so that if you have symptoms, you can bring the tick in and they can look specifically. There are a range of tests that they can look for. And I'm not going to go into a lot of the diagnostic stuff for it, but just know that it's helpful to know where you were in the country when you had the tick bite, and if you happen to have it. The Lyme disease is bacterial, and so it can be treated with antibiotics and it's much more, it's not impossible to get response for late onset disease, but it's much more um, able to treat the initial disease and also prevent long-term chronic disease if it's caught early and treated appropriately.
Yeah.
So, so I just wanted to mention that what piqued my interest besides EO talking about this topic was in the Oregon area, which we don't think, and it's not the central part of the country of the state so much. There was a physician whose son committed suicide secondarily to chronic Lyme disease, which was diagnosed way late. Oftentimes it's years. You'll hear this from EO, I think, with people trying to figure out what was going on. And he was a young man who just was a star and became debilitated, had brain disease, became psychotic. When they finally diagnosed him and he started getting better, he committed suicide.
Yeah.
So it's something to think about. Mental health disorders with all of these difficult to diagnose conditions can sometimes be blamed on, okay, well, you're depressed because you have a chronic illness, but it may be that it's affecting how the brain works. So
yeah, good point. Can you
yeah.
just grab the statistical source for that 90%?
That's
you mentioned?
from the CDC.
Okay, thank you.
CDC has a 52-page booklet on tick disease. So if you just go to CDC website and put in tick-borne illness, you'll get this. You can, I don't print the whole thing off, but yeah, so they have that, and you can also see where these other bacterial and other, some of them are viral, the things that the ticks spread. And the other thing to know is that sometimes they're not spreading just one thing, they can carry several. So so there's that. And then the other thing that I really wanted to mention before stopping and turning it all over to EO is a little bit about prevention and then to highlight the tick removal thing. So for tick removal, you should, and I don't know a lot of people that know this, people talk about putting Vaseline on them or burning them with a match or any of that kind of stuff that will make them withdraw, but not always completely. And so they say you should use fine tip tweezers and just a direct, like a 90-degree pull directly. If part of it's left in, don't dig it out, just deal with it. And then, make sure that you stay aware and watch for symptoms. So you don't necessarily have to run into the doctor at that moment because, again, many people will have a tick and have no problems from it. The other thing is when you travel or when you're working or when you're hiking, just know where ticks may be. And then
they hide in your hair and the nape of your neck, right?
Well,
I mean, I just remember that
they do
from growing up in Missouri.
Yeah, they like warm, moist spots also. So you may have them in armpits and things that you wouldn't normally see when you're getting dressed. And so, yes, around the ears, under the arms and so on, between the legs, around the waist. And
Gail, did you come across anything about removing them from your dog or your pet? Like, is there?
Oh, I think it's probably the same idea that you just pull them out. Yeah.
Mhm.
I didn't run across that, but the idea is that by doing it that way, where you're taking the tweezers and
The
you're
head
grabbing them, body, whatever, that you're pulling directly, you're most likely to get it out of whoever you're pulling it out of. So, so that, if you have animals that have them, obviously you want to get them treated and get rid of them. Then you want to look for, you take a shower when you're done being outdoors. We tend to do a good body survey when we're in the shower. And then when you're going someplace where there may be ticks, think about some type of lotion or oil. Eucalyptus and lemon is one they don't like. There's things like that you can do. Right. So I think we should hear from EO, and if there's any additional questions, I have some references and think that it's just another area to add to our list of very confusing things to diagnose, and how much trouble, I know this is not new to anybody on this call, when the diagnosis isn't easy, how much trouble and how frustrating and you know, life altering it can be for folks.
Yeah, thank you. Thank you,
Sure.
Dale. And it's a really good reminder. I had a friend who in her early 50s who had long time Lyme, but didn't know it, years after she was bitten, and had a stroke, and very impactful young person, and took her a good year to get diagnosed. So that is a really great segue. We're going to welcome on Dolka, and she actually has prepared some slides and a bit of a structure for a talk for about 15 or 20 minutes. So as your questions come up, please, I invite you to put them in the chat. And with that, we'll turn it over to Io. Welcome.
All right. Thank you, Robin. Hi, everybody. It's nice to see some familiar faces I haven't seen in a long while. We're going to talk in my section, as Dale was talking about, we're going to talk about those difficult cases a little bit, which is what we deal with all the time at GreyZone, and focus on the power that lies within the patient and the patient advocates that help the diagnosis to actually improve the odds of getting an accurate diagnosis. So I'm going to share my screen, and hopefully you can all see in a moment what I am presenting. Does that work?
Yes, that's great. Thank you.
Okay. All right. Okay. So, well, hold on, because I lost it. It's going to be here in a minute. Okay. All right. I want to start with a question. And my question is for you to think about, what is the most important thing at the doctor's office? And maybe you can put in the chat, we can take a look at it. But if you think about who is there and what you're there to do, what do you think is the most important element in there? I am going to tell you what you probably already know, that it's you, the patient. I know we have a lot of advocates here, but it's the patient. The patient is actually the most important element in that room, because the patient or the patient and their advocate, they have the power to help the doctor help them. And a lot of people don't understand that power. So you as the patient can help your doctor find the cause of your symptoms with a little help from excellent preparation. I want to talk about two cases. The names are different, but the cases are real, to illustrate what I'm talking about. So the first one is Christina. She was a 30-year-old woman. She gradually fell ill and became confined to her bed. She could not work nor spend time with friends or family, and no one could figure out why she was so sick. She feared that she would never become well again. Tom is an elderly man, and he suddenly fell ill. And his doctors thought that whatever he's experiencing is basically because he's too old. If I had a dime for this, I would be very rich every time I hear that. So no treatment actually worked for him, and he continued to deteriorate, and his family was actually afraid that Tom would die. Now, it's not a surprise for advocates for sure, or for us, that neither Christina nor Tom actually got any better, because without a diagnosis that is accurate, timely, or complete, and also has been communicated to the patient, it's pretty rare to see any improvement. If you don't know what's wrong, it's kind of hard to fix it. It's like the cases that Robin was talking about before. If you don't know what has caused your symptoms, it's kind of hard to figure out how to undo this. So all of that can be changed by understanding the process of diagnosis and trying to improve that. Now, I wanted to take a moment, talk a little bit about the diagnostic process. Most advocates know this very well, but we have people who are not advocates on the call. And I think it's extremely important to talk about three elements of the diagnostic process. And the first one is the uncertainty. Especially in cases where someone presents with long-standing symptoms, It's not like you're having a sharp pain in your abdomen, you go to the ER and you're diagnosed with appendicitis. But think about somebody who's chronically ill, chronically meaning anybody with 6 months plus of symptoms without an answer. There's a lot of uncertainty as to what is actually happening. And we see a lot of patients who are not aware of that uncertainty. So their expectation is, I'm looking for that button. I'm looking for somebody who will finally, within, 1 or 2 appointments, will be able to tell me what's wrong and fix it. And I think that's a very reasonable thing to hope for. But unfortunately, it's not how this process works. So uncertainty is an uncomfortable place to be, both for physicians or providers and for patients, but it's a necessary place to be. If you start feeling comfortable in being uncomfortable, then you allow the space where questions are asked. Why is this happening? Why does this not work? And then you can come up with an accurate diagnosis. If you immediately jump into what is the first thing that you think might be going on, then you kind of close that space of uncertainty. So that's the one element. The other is that, especially in cases that we're talking about today, from what Dale was talking and Robin and myself, the process takes time. And it's painful not to have answers for a long time, but the process does take time. And it is important to have that in the back of your mind as an expectation. And the process involves having what's called working diagnosis. So your provider will hear your story, will have a sense of what they think is going on, and then they will have 1, 2, or 3 ideas about what might be the cause of your symptoms. So they will form a working diagnosis with which they will move forward to try to prove more or less that this is correct. They'll do some testing, maybe you'll try a medication, they'll see how you respond. So the first thing you hear might not be actually your diagnosis at the end. So it's important to also have that understanding in mind. Now, what can you do when you are in the diagnostic process and you are a patient? Remember, we're talking about how there's so much power in your hands, right? You are the most important element in the room. Now, the most important thing you can do is prepare for that appointment and also not to go alone, but that's the last bullet in my slide. All advocates tell their clients, you got to prepare for those appointments. And the reason why is because it's crucial how you tell your story. Not your life story, not about everything and anything, but about what happens that is the reason for your visit that day. What happened that started your journey with the symptoms. You want to write down your symptoms. You want to talk about when they started. I was walking down the street, I fell and hit my back, and since then my knee is hurting. You got to try to put some things in context. Sometimes it's hard, especially if you are chronically ill. A lot of people don't have a clear head anymore. And our suggestion is always, bring a person that knows you well, your parents, your significant other, a close friend, whoever has seen what you're experiencing, bring them with you when you take some time to write down your symptoms and your story and kind of run things by them. Bring also your records, especially if you're seeing a specialist that is not part of your regular team and they are outside of your regular healthcare system. So here in Seattle, for example, we have a big system at the University of Washington. If all of your physicians are there, and then you have a referral for a physician who is at a solo practice, there's a big chance these two won't be able to exchange records very quickly or easily. So if you have records, bring them with you. And if you don't know what to bring, definitely an advocate can help you sort that out. And also bring your medications and your supplements. Most people don't do that, but it's important because many times there are side effects of medications, especially when you combine them, that might be part of the story you are describing, especially if it's a chronic situation. And as I said before, don't go alone. I'm an advocate and I rarely go alone in these meetings because I want to focus on being a patient when I'm the patient. And bringing a family member or a friend that knows you very well, or if you don't know anybody that could fit that role, hiring a professional advocate is extremely important. When you're there, you want to talk about the story that you crafted. You want to talk about how it feels being you experiencing the symptoms and why it's important to you, and how they affect your life. It's important to be able to do that and have somebody else be your eyes and your ears and somebody take notes. And that's somebody, if they helped you put your story together, they can also remind you, oh, you know what, you also wanted to talk about A, B, C, D. It's extremely important to do that. So those are the things you can do. Now, let's take a look at what you can say. There are millions of things to say. I just wanted to focus on the very, very basic things here, and we can discuss about any questions you have later. The two most important areas, folks, is questions about the process and a discussion with your provider about what are the things that you collectively decide you are appropriate in your case. So in terms of questions, ask the physician or the provider that's there after you've talked to them about what is your story and what's happening to you. What do they think is actually going on? What do they think the presentation of your symptoms is? What is the cause of it with, what happens in their head? Also ask them, what else can it be? This is an important question. So providers think about a couple of different diagnoses, and it's important for them to not launch onto the first thing that they think about. So by asking that question, you're inviting them to tell you, okay, what else are you thinking about that this could be here? So not to kind of focus on the first thing. And then talk about what are the diagnostic steps forward. Okay, so you think I have condition A, how are we going to figure this out? Are there tests to do? Are there medications to try? And how long is the process going to take? That is not necessarily a set kind of answer. Doesn't have a set kind of answer, but you can get a sense, and it's all about expectations. So again, we started talking about expectations and how quickly an answer can come about. This is also about this process as a patient. Is it something that's going to be quick? Is it multi-step? Usually it is. So it's important to get a sense of all of that when you're starting.
We had also somebody just type into the chat, and I won't use her name, but when being treated for a brain tumor, her husband took a video of her trying to ask a question, which she couldn't get out. And it was after her biopsy, and it showed that there was swelling that she couldn't communicate effectively. And so her doctor actually found that piece of information very helpful. So in terms of what to provide and help, doctors get a sense of who the person is, just like what you're saying, is super helpful. Yeah, I
agree. No, that's a great point. Actually, we have had experience with a patient who is extremely symptomatic. She has a neurological condition, and that makes her have events that are hard to describe. And a picture is 1,000 words, right? So you show a physician the video, and they're like, oh, now I get it. Because when you see the patient, they may not be like that. Yeah. So yeah, that's a very, very good idea. That's a very good point. So the other thing that I think is important to discuss and really promotes shared decision making, it's a whole conversation about, okay, this is the universe of the tests we could do and the treatments. What should we do right now? And it should be, in a perfect world, a decision between a provider and a patient. If a test X costs $1,000 out of pocket, but it's going to be the perfect test, it's important for you as the patient to be able to decide what you want and how you want it. And we have seen, actually, I think it's extremely important to experience that as an advocate. Many times we see patients who have been ill for a long time, and when you come on board and the physician starts saying, oh, we can do X, Y, Z and go very fast, they're taken aback and they actually push back, which is not what you would expect. You would expect people to say, oh yeah, please, let's jump on it. but they have been sick for so long and everything is out of their control that this seems more out of their control. So it's extremely important to decide together what makes sense here to do. So those are kind of basic things again, and they may look very overwhelming to patients. And that's where advocates can come in. And as Robin said in her email, I have started using the term of diagnostic advocate, especially in the Society to Improve Diagnosis in Medicine community that I am involved in the last 10 years, because I've seen in our practice at least how advocates can make a tremendous difference in improving the rates of diagnosis and decreasing the time to diagnosis. So diagnostic advocates really focus on that. That's kind of their laser focus when they work with a patient. That's what we do when patients come on board. And their focus is to decrease the time to the accurate, timely, and complete diagnosis, and then to make sure that this is communicated to the patient. I'm sure advocates here can share stories about providers actually knowing what's wrong. They have classified in their head what is the pattern that they see. They treat the patient, and sometimes patients don't even know what's their diagnosis. They're like, yeah, I'm taking this drug for this medication, for this symptom. I have no idea what I have. So the accurate piece has to do with making sure that all of the ducks are in a row. You know, there are no symptoms that don't fit the pattern. And all the diagnostic testing ideally, you know, has been done that needs to be done to confirm this is firmly now a proven diagnosis, not a theory about what's going on. It's not possible in all cases, especially the bizarre kind of situations, but it's important to strive for an accurate diagnosis. The timely piece has to do with decreasing that time to the answer. If patients come to you as an advocate and, you know, they've been around for 2 or 3 years, they don't need another 3 years to figure out what's wrong. And actually, if they go alone, we believe it takes much more time than if they go with a diagnostic advocate. So we see how important that is. And the complete piece has to do with answering all of the questions. If I have 10 symptoms and 5 of them fit a specific diagnosis, but the other 5 don't have an answer, is that a complete diagnosis? Probably it's not. So it's important to try to answer all of the questions. And if you can't, to then at least acknowledge the questions that are not answered, and then communicate all of that to the patient, teach the patient about what's happening to them, and make them understand their prognosis. What is this disease going to look like in 2 months, in a year, in 3 years? Is there a possibility to improve? Is this actually going to go downhill? The patient needs to be aware of what is happening to them so that then they can make educated decisions about their care. So how diagnostic advocates do this job is how we have actually done this. I can only talk about our model. I'm sure that other advocates that focus on diagnosis have their own, but a big part of it really focuses on medical records. So we obtain and organize these medical records, and especially for patients that have been out and about trying to figure out what's happening to them for years. Most advocates know it's a daunting task. And we collect and organize them, and we actually go through them. That's why it's important to have people with clinical expertise as advocates, because the idea is that you take your fine-tooth comb that nobody takes anymore because there is no time, and go through the process, go through all of the records, try to tease out what we call noise versus signal, like what is important here, what is, you know, not worthy of, you know, repeating, and try to find the pearls. There are so many pearls in there, things that have been identified through diagnostic testing that were never followed up, or kind of really borderline findings that nobody kind of thought to look into, but actually in the big picture, they make some sense to follow up on. So we do all that and then interview the patient extensively. That's the opportunity that is there. The patient and the patient advocate can talk for hours. the patient and the provider can talk for 20-minute chunks, at the very best case scenario for 40-minute chunks.
Mhm.
So we take all the time up front and we go through that to create clinical relevant summaries. So if you're seeing cardiologists and rheumatologists and somebody else, we go through all the records and then we create a summary based on what you've told us and what we found in the records that goes to that physician before the first time you see them. So when you enter the room, that physician ideally has read this, or they have a moment to read it. It's not usually long, it's just very precise. And they have their big picture. So we're helping them narrow down that funnel from the beginning. And then they have the opportunity to talk to you. So they are not agonizing, okay, I'm gonna figure out what is happening. They kind of know the big picture, and then the patient is allowed the time to talk about their lived experience and their symptoms. So that's the pre kind of visit thing. And then in the visit, we're there, as all advocates very often are there with their patients. And we facilitate the communication. We make sure the right questions are asked. We have researched the symptoms and the conditions and the testing that usually goes along with what's going on. And we bring about questions that are relevant. And then we make sure we follow up on the tests and the next steps. And this is so important because there are 3 elements that we know from studies in places outside the hospital setting about where diagnostic error happens. The number one thing is in history taking. And that's where our first column comes in. We spend so much time in history.
So interesting.
Yeah, we spend so much time in that. And there's a reason why we do that, because that's kind of the number one reason for diagnostic error in that setting. And then the other 2 reasons are the follow-up on the test, which again, we're making sure we do. Oh my God, I blanked out. And the third one, which I blanked out and I can't see my notes for some reason, so it will come to me later.
That's okay. Yeah. Can you talk, because I think most people are maybe not familiar with CEDAM, that you've been involved with for a number of different years. And it gets to the research around diagnostic error, which could you just maybe just quickly just say who they are and what information is available, maybe direct advocates and patients and their families to this great resource?
Yeah, happy to. So CIDM is the Society to Improve Diagnosis in Medicine. And I know a few of the people who are here are aware of the organization and we have been together in some of these meetings. And it's been around for about 10 plus years. I think I'm involved in the patient engagement and the practice improvement committees there for almost 10 years. And the purpose of it is to make the diagnostic error kind of an area that is talked about, because it's not an easy subject for medical providers, and then an area that is researched in. And there's a lot of research from various wonderful institutions like Johns Hopkins and Stanford and the University of Texas and Baylor, and a lot of different institutions now that focus on trying to understand what is happening and what are the elements that go into diagnostic error. A huge chunk is about how providers think. But then there are other things that have to do with the system and have to do with the process. And where patients can help is in the process, which is what we're talking about today. And
I just put a link. I just put a link to the organization in there.
Yeah,
for
so
everybody,
you can go online and see. And we're changing things right now, so things are going to look different in the next year. But it's a wonderful organization from people that really, really care very deeply about getting it right and the effect that it has when we don't, and how important it is to be able to talk about it.
Yeah, there's another question from Anne Llewellyn. Thanks, Anne, for joining today. What do you see most missing in medical records?
Most missing? That is a good question. Well, I would say follow-up sometimes. It's like, okay, we see this and now what? What is the next step? So that is missing often. It's a very good question, Anne. Thank you. I don't know. I know Sarah Jane is on, so I'm wondering if she can talk about what is missing. I'm thinking about what's there that shouldn't be there, but about what's missing, I don't know. Sarah Jane, I don't know if you're here.
Yes, I am. I could feel you about to call on me. I had like an ESP moment and I was like, oh, I better make my screen big. That is a great question. I think that 90% of the time medication lists are inaccurate. Often allergies are inaccurate. I'll try not to sound too jaded. Diagnosis lists are often inaccurate.
Yeah, to that point, if I may interject just a moment, that's a great point. You're supposed to document your working diagnosis and the alternatives, right? And I would say the majority of the time, we don't see that in the record. And it's kind of shocking. If you're looking for diagnostic error, that's kind of shocking. Maybe it is actually in the head of the provider, but it has to be down in the record. And it's not very often. Sorry, Sarah Jane, keep going.
Not at all. I think that what tends to be the most accurate on a medical record, which is an easier way for me to think about a medical record in general, is the narrative piece written by the provider. And it stands out in your doctor's note because it's a sentence. It's not usually a grammatically correct sentence because us nurses and doctors, no one makes us, so we don't use punctuation. That is the part where the provider is summarizing what happened. That part is the most valuable. And then it goes down steeply in accuracy from there, I'd say.
Yeah, that's a very good point.
And Kai Corbin here is saying that she's also seen too long a list of diagnoses that are never given to the patient by all the providers. I mean, sometimes there are surprises, right?
Yeah.
And I also want to thank Marcy for, as Sarah Jane was saying, current medications and unnecessary medications. They were both saying that at the same time. So I have a question from Krista Mutaleonis. How are patients supported with known tests that can produce false negatives? For example, celiac disease, where patients actually have the disease then are dismissed due to inaccurate results. And we see this obviously with POTS and lots of,
Yeah, no, that is a good question. I think that, first of all, again, it's important to talk about expectations with the patient and alert them. And so I think it's important for an advocate to read ahead of time about the possibility of false negatives or even of false positives. And then when the results come about, to discuss with the provider, is there a possibility there is a mistake here, and how do we just replicate? The easiest thing to do is to run the test again. So you're just playing with numbers, right? But for example, with celiac disease specifically, people that don't have the antibody class that the tests are looking for will test negative, and that's a false negative. So if you don't know that, it's impossible to actually look for it, right? But an advocate can learn about it and then can have a discussion. And then you bring in your patient for that discussion, talk about the possibility, talk with the provider about what you can do. I'm of the mind that you want to have a win-win-win. It's not about talking down to anybody or about making anybody feel bad about what they miss or what they don't know. That is not the purpose. The goal everybody is working towards, including the provider, is getting answers and getting the correct answers. So everybody has to work together. And the patient advocate's position is to ask the right questions and to be educated themselves.
And I see Chris Price here, who's an advocate and former cardiologist, said part of the reason for med list being wrong is that the patient does not bring a complete list of their meds with them. So always have this up to date and bring with the patient. Thank you, Chris, for that.
I cannot agree more about that. And I know Sarah Jane is saying yes. And That's why I said in the previous slide, bring them with you. And in our case, there are many times where we do med reconciliation very often for patients because they have tons and tons of medications that they take. And even that is an art, because you'll have somebody say, oh yeah, I take the same dose. And you're like, well, could you please go and actually grab that bottle and read from that bottle? Are you actually taking, the dose you're telling me? And often we'll be like, oh no, actually this new bottle says I'm taking a different dose, and nobody ever caught it. Nobody knew about it. And you're actually actively looking for the correct information. That takes a very proactive approach. It's a little different.
How much of your client work is medication reconciliation?
That's
Like, do you
not,
do that for all clients?
we do that for all our long-term clients. So
Mhm.
for them, it's about, once a month. We have a specific list.
Wow.
Many times we will ask them, could you please take the time to review it yourself or fill it out
Mhm.
yourself, and then we'll go over it together.
Mhm.
It depends on their cognitive capacity, because
Mhm.
sometimes we have people who are not very much able to do this on their own, or people who are very much able to do this on their own, but then it's really important to go back and go through every single thing and say, okay, do we have this right? And often they will forget, and you got to compare what they told you the previous month, and also to compare what has happened in between with provider visits where new medications
Mhm.
have been added or subtracted. Some
Mhm.
of the previous have been subtracted, and see, are they actually now implementing the new care plan, or are they in the previous mode?
Yeah, and I would say that like the pharmacy often has it wrong because they've got your old meds on there and the new meds aren't right. And so
Yep.
just using that list is really not helpful.
Yeah, it's a start, but yeah, it's not the Bible, right? It's like it could be wrong, and then a patient can have 3 pharmacies: a specialty pharmacy,
Mhm.
a mail-in pharmacy, and the pharmacy next door. And who has the correct list? And probably nobody, because there's something extra happening at home.
So Beth Barnett is asking a really good question, which is, have you ever tried getting the prescription data from the pharmacy? What prescriptions were filled in the last 3 months in terms of a different way of getting at the
Yeah,
medications list?
yeah, we have, and we do that often, especially when there's, a question mark as to what's going on. But
Mhm.
you fall into the category that I was talking about before. If you only know about one pharmacy and you don't know about the rest, then
Yeah.
you may have kind of blanks in there. And you
Um,
always have to get the patient's permission, right?
Mhm.
Right. And Beth says the insurance company has the correct list unless not covered by insurance. And some people do pay out of pocket, or they have a list of supplements that might not be included. And
Yeah.
yeah.
Supplements are often left off by very smart people who think, when asked about medications, think about what was a prescription. So,
Yeah.
extra asking, because sometimes the supplements are causing complications. And
Mhm.
I think the harder the diagnosis is, the more providers somebody has visited, the more likely things are going to get missed.
Yeah.
That's very true. Actually, Dale, to your point about supplements, we have a patient who had an undiagnosed neuropathy, and we went through the supplement list and we saw that they were taking, like, I don't know, a big amount of B6 vitamins. So when we got them to the right physician, they checked and their B6 vitamins were through the roof. That is a known toxicity that produces neuropathy as a symptom, and sometimes actually is non-reversible. And they didn't know that.
Whoa.
Nobody knew that they were taking this. And when we talked to them about it, we're like, you gotta, put that in some kind of a lower dose. They were really hesitant. They didn't understand the connection. So it was important to walk them through that.
Yeah. Things
Really
that some of the supplements that are in and of themselves not a problem, but mixed with some of the medications also. So bleeding complications, if you're taking like a lot of vitamin E and you're on some other medication that can be affected by that. So or absorption, things that cause malabsorption. So it's hard. The other thing I was going to say about the medical record is so much crap that you get when you order the records.
Yeah.
That it's sometimes the answer's in it, but you can't find it, beneath all the, excess pages of garbage. And that's another challenge.
Yeah.
Is there a solution to that?
The
No,
medical summary.
with an EMR, the EMRs are terrible. When you request records, you get you may have one lab value on a page, and you may get 200 pages of lab values. It's nuts.
Yeah.
It's nuts. Yeah. So somebody somewhere is going to have to pull the major EMR people together and say, how do you do a more concise report out when somebody requests complete records?
Marry it with Chat GPT.
Yeah. maybe,
Honestly, I mean,
maybe. Yeah, yeah.
Maybe there's a role. Yeah.
yeah.
I mean, in our practice, it's exactly what you're describing, Dale, that necessitates the summary. Because if you see a patient as a provider that comes to you with this amount of records,
Mhm.
what are you going to look through?
Yeah.
So we know that there's no room and no solution right now in the system. So we take the time to do that ahead of time. And that's the only way we know how. But I agree with you. There's so much room for automation of all of that. It shouldn't be something that you do like this.
Yep.
Well,
And I think it's another thing that contributes to the differences in health outcomes that we see
Yes.
with people that are not English speaking as a first language and, don't have much health knowledge themselves to begin with. And it compounds every other social determinant of health when you're a novice yourself as the patient as to what's important.
So yeah, it's important that if people can't have advocates, that we teach them and train them about the medications, the medical records. And the other thing I always think is so important is to ask about what we learn from the tests that are being ordered before they're
Yes.
ordered, so that people aren't getting, tests they don't need. They're all education pieces.
So we
Absolutely.
have just 8 minutes left, and we do have some things in the chat that I want to address. One is to go back, Dale, to somebody asked if there were any diagnostic tests regarding Lyme disease specifically.
Mm-hmm.
Do you know of any?
Yes, and let me gather that. But I know EO had a couple things she wanted to finish out with, including what happened to those two patients. So
Oh
how
yeah,
about
thank
does
you.
that? Well, I find the
Okay.
questions.
Okay, it's fast. I'll go through it
Okay,
fast. So
cool.
anyway, that's what the advocates can do. So we talked about that. So going back to those two people that actually got advocates involved. So Christina, you remember she fell gradually ill. So she actually got us involved, and she was diagnosed accurately after 2 years of being sick with 2 rare diseases. And she's now able to work, and she's now able to enjoy life again. And not only that, but she got involved actually with the organizations around her rare diseases. And now she's kind of paying it forward, which is wonderful and very much in control of her life. And then Tom actually, he was not in a position to advocate for himself cognitively with what was going on. And his family stepped in, and they partner with us in this case. And he was diagnosed accurately within 6 months. Actually, there was a medical device that was his problem. And that got fixed. And after that, he returned to his previous health. So there was no issue about being old and not needing any support. So I want to close with just these 3 things to say that you, the patient, or you, the advocate, can really change the trajectory of things. And if there's only one thing anybody remembers, is that there is so much power in that role. So get involved with your provider, ask, listen, learn about the things that are going on, which goes to what Beth was talking about before too. Focus on the history and the communication. If that's too much and you're able, please hire an advocate, a professional advocate, and prepare, and they will help you prepare and support you, and they will respond to all of these things that are happening in the diagnostic process. And then close the loop, like go back to the physician. If you are actually needing to do a test, do the test. If you have second thoughts, discuss about the second thoughts. It's okay to have second thoughts. and then push forward. And that's where you have hope and perseverance, right? You got to be able to, take charge of the situation. So that was all I wanted to talk about today. And if you know someone who has made a difference in their own diagnosis, we are collecting stories. So please email us at hello@greyzonehealth.com and just say, I have a story, and we will send you the information that we're trying to collect. Thank you so very much.
That's great. And I know that we have a couple hands up, so I will get to you. Hang tight.
Okay, let me
So in
quickly
the
do
meantime, yeah.
the diagnosis. Okay, so if you have rash only, and you've been in an area with Lyme disease, that's usually a clinical diagnosis. And they don't really recommend, and actually rash by itself with no other symptoms tends to resolve and not become a systemic disease. So that's important to know. There are serologic tests, so blood tests that are highly sensitive when you have disseminated Lyme disease. And that can be a two-step process, and it depends in part on whether it's an acute circumstance with the symptoms or chronic. So you need an infectious disease or person or somebody with primary care who's well-versed in this to know what to send. And for
Can I
someone
just jump in there too? Because I know from my friend's experience that there are Lyme specific practitioners
Yeah.
that are throughout the country that are very important to see, because there's some controversy over the serology around the blood tests, right?
Well, yes and no. And I don't know that you have to. I mean, I think if you find an infectious disease person, even if they're not a Lyme expert, you should be able to get the right answers. And almost every major center has somebody, has either private or docs associated. That part of the limitation. So if you have longstanding, you're going to go for a certain type of testing. And if you are, if you have symptoms for less than 30 days, the best test is probably a Western blot that's specific to IgM, the acute phase response that you get. And much of the chronic disease is associated with IgE, which is more like the allergy type immune response. So it really does depend on where you are in your symptoms and what you think your exposure was, if you know when you had a tick bite. The other, and you don't necessarily using serology or blood tests for whether you're an acute or convalescent, or whether the therapy is working, isn't really helpful. So you don't need a bunch of lab tests once you get the diagnosis. And then the one other thing is that you can get false positive test results with some of the tick-borne infections and autoimmune disorders. So the whole person always has to be looked at. What do we come with? What do we present with? That's part of our core. And then what are these new symptoms? And so I think that's the important thing. There's one other thing I wanted to mention really quickly is there's a condition called alpha-gal syndrome that can be associated with tick-associated illnesses. And it is crazy, but somehow the tick infection stirs up an allergy to alpha-gal, which is a sugar process breakdown that affects your eating any type of animal protein. And so it's fats and animal proteins that's non-primate.
Wow.
And so you can be all of a sudden allergic to a hamburger or allergic to milk or something like that. And
So
there's no, and let me just mention, there's no therapy for that. And it does tend to resolve, but over like 4 or 5 years. So it's something to think about if you all of a sudden develop a meat allergy to something you've been eating your entire life, that maybe you seek out someone who's a specialist and say, maybe I've got Lyme disease or one of these other things and I just didn't.
I
know it.
think that we need to do a community conversation online because I think there's
Yeah.
a lot to talk about.
Yeah, maybe.
And we're right. Thank you so much for bringing forward all of these potential issues. And I do want to get two last questions in, one by Kai. So Kai, do you want to go ahead and state your question?
Okay. Thank you. Well, since we don't have time, I guess I'm not going to go into like a really meat of the question, but thank
Okay.
you so much for this opportunity because I really tried to do what EO was describing, but to be honest with you, I'm kind of giving up at this point because I really haven't met a doctor who is comfortable discussing that, the depths of conversation like EO is able to, conduct. And then there's like a more than a year waiting list, right? So at this point, I actually just find the best, like for instance, do you know Dr. Stephen Phillips in Connecticut? He is excellent in Lyme. I rather just refer a good doctor because I'm just not gonna really, help that much. That's just my honest feeling at this point. Or maybe refer to, advocate like a EO.
And I do think thank you for that comment. Important to refer always when you know that there are experts specifically. I'm going to go ahead and just jump on over to Chris Price to close us out here. We're at 12:01. Chris.
Mine was more of just a comment. That I think everybody needs to realize is that if you don't have a good communication with your physician or your provider and all that, find a new one.
Yep.
There's no reason you have to stay with that one. There are many out there. Yes, your insurance company say you have to stay within the thing, but if you don't, it is a personal relationship. And if you don't have that relationship with the doctor to be able to feel comfortable to discuss those things, or they don't feel comfortable to discuss back to you, change doctors. I mean,
Thank you for
there's
that.
no offense. I mean,
Thank you.
that's the biggest thing.
Yeah.
Totally.
So thank you for that last word, Chris. I want to also thank our special guest, Dolka from GreyZone Health, and Dr. Dale Reisner, who's given us a lot to think about today, especially on Lyme. We're going to have to maybe stir up some Lyme experts throughout the country to bring back to you. And thanks everybody for attending today. It was great to see so many longtime friends and advocates and folks. And we will be posting this presentation on our website along with EO's slides. So that will be posted hopefully later today or tomorrow morning. So thanks so much.
Thanks,
Talk
you
to you soon.
guys.
Thanks, everybody.
Good job.
Bye, everyone.